Let's thank everybody for joining today. Julie Miles is on our board, and not only that, but she does many things for SRF. And she's got Miller, who's 8.
Yes,
Hey,
almost done.
almost 9. I knew his birthday was coming. Good. And she's gonna host tonight. So I'll let you go ahead, Julie.
Yes, so thank you, Lauren. I'm Julie, and I'm very excited to be moderating tonight's very special webinar on a topic that is just so near and dear to my heart, not only as a mom of a SYNGAP1, but as a licensed physical therapist assistant. So as Lauren said, we have an 8-year-old son, Miller, and he was diagnosed in July of 2020. And we live in upstate South Carolina, but we are from Louisiana, and that's how I know these 3 individuals. We have 2 other children that are ages 5 and 3, and my husband Michael and I have been volunteering with SRF since 2021, and I've been on the board of directors for about a year and a half. But a very special way that we give back to the SRF community is we host the annual Scramble for Syngap here in South Carolina. So the idea for tonight's webinar came to me after seeing just post after post on our community page about various therapy topics. Majority of our children participate in some type of therapy, but in most cases, they're the first Syngapian that their therapist have ever worked with. So my hope for this webinar is that not only it can be an excellent resource for parents, but hopefully a resource that we can all share with our therapist, that will provide some actual experience and tools from therapists who have worked directly with a SYNGAP1 patient. And for many of those years, we didn't know Miller had SYNGAP1, but the development and the process and progress really looks similar, regardless of him not having that diagnosis. Not much changed after that. So anyway, with that being said, we're going to get started. Tonight's speakers are coming to us from Melanie Massey Physical Therapy in Shreveport, Louisiana. And Miller began working with this group at 10 months old. And then not too long after that, I started working with them. So I would work a little bit, bring Miller to therapy, bring Miller with me to work. And so we just really built a really special relationship with these therapists. So not only were they his therapists, but they were my coworkers and friends and mentors, and so much more than that. They just became family to us. So needless to say, I have a very special place in my heart for them. So we're going to start the evening with physical therapy, and then we'll go to occupational and then to speech. Each speaker is going to do a small presentation for us, and then at the very end, we'll take questions after all 3 of them have a chance to speak. So if you have questions, make sure to write them down, or comments, or just anything that you want to talk about with them until the end, and then we'll go through those. We had some people submit questions on the on our group page, and then had some that sent some to me personally, and so I've given those to the therapist, and then we'll discuss those all at the end. And Lauren Perry, I know she introduced me, but she's going to be helping us tonight as well with moderating. Lauren is mom to Will, who's 13, and they live in Colorado.
Yeah.
Thank you, Lauren.
Okay.
You guys are just in for an absolute treat tonight, and so I really want to be respectful of their time, and so we're going to get started first with Ron Payne. So Ron is a licensed PTA and the director at Melanie Massey Physical Therapy in Shreveport, Louisiana, where he has been employed for the last 18 years. Ron received his degree from Bossier Parish Community College. Ron enjoys teaching future therapists in our local PT, PTA, and OTA programs, helping them to learn about primitive reflexes and atypical development. He has many years of continuing education courses that include torticollis, pediatric brain development, NDT and DMI training, as well as intensive model of therapy with the NeuroSuit. So Ron is I have to just say, very special to our family. He was the very first therapist that put his hands on our child. And so we went through a lot of things together, and I consider him so much more than a mentor. He's family to us. So you guys are in for a treat. I've got my notes ready to start taking because I always learn something when I hear from Ron, and I hope you guys do as well. So Ron, let's get
Thank you
started.
so much, Julie. I appreciate that. Um, and thank you all for coming. I'm really excited about this and about the opportunity to get to learn more about each one of these families, and hopefully to be able to be some assistance to anybody who has any questions. I'm going to keep my presentation kind of brief because I know myself and I can tend to be long-winded. And since I am going first, I don't want to take up everybody else's time. So I'm going to go through my little presentation here. And just kind of give a little brief thing. And let me bring up, see if I can actually share this so that you guys can see it. Let's see this and that one and there. All righty. Everybody able to see that? Good. All right. So just kind of want to give a little brief rundown of what PT looks like for those of you. I'm sure a lot of you are already in therapy, especially if you do have older kids. You have been through it for probably quite some time. And just kind of what we notice, obviously, this diagnosis is a very rare and unique one, but some of the traits that these children have are very, very common among other diagnoses and a lot of the kids that we see. So although we as therapists don't often get to see some of these more uncommon diagnoses, we do see a lot of the same things as far as physical aspects. So what we look at with PT, and what kind of our biggest thing is gross motor control. And what I mean by that is, those are the large motor movements. We're not looking at where OT is going to be more of the fine motor and what they do with their hands, and we're going to be looking at the global aspect of it in the major milestones that they reach. One of the biggest things we look at, and a lot of times what parents will notice early on, even sometimes like in Julie's case, years before they get an actual diagnosis, is just the delays. That the children will just not be reaching those typical milestones at the appropriate times, and it's more often than not a more significant delay than just maybe a couple of months within the first year or something like that. They tend to have a harder time because of their low muscle tone, just sitting and rolling and all those things. So we look at that, and then we look at primitive reflex integration. I'm gonna get into that a little bit more later, and how that kind of goes into reaching some of these motor milestones. And then for us, there is in those early years, especially within that first year of life, there's going to be a lot of overlap with OT as far as the things that we do, and which we try to do that at our clinic. We try to do that anyway. We try to have overlap with everything we do, so that anything that OT or speech is working on, if we can do that in PT, then we will try to integrate some of those things as well. So yeah, but especially within the first year, because those first few months, especially, there's not a whole lot that they do. That they may, you may see a lot more overlap in as far as the things you're working on. So when do you start? Well, hopefully that you notice these things pretty early on. And I think that was one thing. Julie, being educated in this, she was aware of that, I think, fairly early, even though it was her first child. And sometimes parents, if they don't have that other child to compare, like, man, their sibling did this, way earlier than this and stuff like that. They may not know. So usually, if that's the case, then a doctor will see that, at their regular checkups. They'll check things, and they check reflexes, and ask the parents the questions to see, are they, hitting those milestones on time. And so often we'll get those referrals from the physician because they notice it first. And then how often do we do it? We recommend, and we'll talk a little bit more about this later at the end. I'm just going to throw this one out for now. from birth to 3 years. We say 2 to 3 times a week. I say that because in most cases, most states have an early intervention program. And so if you can get those services as well as outpatient services, then that can increase the amount of assistance that you can get with that. And then the first year especially is so important because there's so much that happens in the first year that's going to affect them for the rest of their life. So we want to get them as much as we can and as much as they'll tolerate within that first year of life. And then also that obviously you have to take into consideration parent schedules and, their ability to be able to make those appointments. And then after 3, we'll talk a little bit more about that later because I'm sure some parents are going to have questions about that. I think that actually was one of the questions that somebody had submitted. But after 3, that's an individual situation. I think for that, it's obviously you take into effect, because, kids get burnt out. That's with anything, especially around that age, they can, get to where they're, not making as much progress because they're just tired. And the routine, it gets kind of monotonous. But do you pick up more of that because, maybe they're hitting a growth spurt or they're reaching milestones more. So you're like, okay, we really want to attack this now. It really is an individual thing. Do we need to cut back? Do we need to take a break? Because that's an option as well. Sometimes you just get to a point where like, man, we just need to take a month or 2 off and just see we've kind of plateaued. Or just life, sometimes you just get overwhelmed and you just need a break from that. I always tell my parents that you think about, for a lot of these kids, this is their extracurricular activity. If you had a child who excelled in athletics or academics or whatever it was, if they had a hobby that they really enjoyed doing, you put that effort in. You see these parents that are taking their kids to travel ball games and they're going on the weekends and they're doing all these things for the kid for something that they want to do. For these kids, this is something that they need. So I always try to encourage my parents to think about it that way. I say, put the same amount of effort into this. But also you have to think about with those parents of the, typical development kids who are, having all these hobbies and activities and stuff like that, you also do get a break from those. Baseball season doesn't last year round and things like that. So so you got to think about that too, is that, sometimes parents just need a break because they get burnt out and you don't want that to happen to where this becomes too much of a burden. And then as far as options for services, we want to discuss that too. And I'm sure Morgan or Hannah will probably touch on that as well. But we did talk about, I mentioned early intervention programs. But there's also, after they age out of that, a lot of places have school-based program. And if your child qualifies, you can even get that even if your kid isn't in school. Even sometimes we've had parents here locally that their child stays home. They don't go to a preschool or anything like that. But the school board still allows for that. And the therapists will actually come into the home. They get therapists, they get special educators that come into the home. So there are options for that as well. Adaptive physical education. So that's another option to where, okay, maybe now we can back down because if you're getting, PT, OT, and speech in the home, we can back down some of those outpatient services once we hit 3 years old. And, school, depending on where you are, because not all school systems are as adequate as others. I know a lot of, like in the Northeast, especially, done a lot of continuing education courses up there. And most of the therapists that I've met up there that were local were school-based therapists. And I feel like that's where they get the majority, like all of their equipment and everything like that is done through the school. They do a very good job of managing that stuff through the school, where here locally, that's not the case. I know here, Mississippi, Texas is a little bit better, but even there, it's still not the best. So I know there's definitely room for improvement there, but that's a little bit above my pay grade. But I mean, that's something that we try to lobby for here locally as well. All right. Sorry, I know I said I was going to keep it brief, and that was a lot. So I'm just going to talk a little bit about, what we look for. And this is kind of what we'll, answer questions about this later. This is just kind of a typical development, and this is why we do things the way we do them when we're looking at, reaching milestones, building skills. And you got to think about, you've got to have a good foundation to build on. I always try to say, that you've got to have that solid, stable support A lot of my younger parents don't get this analogy, but I always say that if you can imagine, like when you were a kid and you had that old rickety swing set in the backyard that wasn't anchored to anything, you get on that thing, try to swing as high as you could, and the higher you got, the back legs of that dang swing set would come up off the ground, and you could feel the chain go slack and all that. I said that's kind of how it is when you don't have that good stability in your body. Is that if you don't have a solid foundation for all the other muscles to work off of, then you're not going to be able to get that good stability and mobility and that fine motor control further away from the core. So the way we develop control in, and this is typically in the first year of life we're looking at, we develop usually head and shoulder girdle first. They start off where they're kind of curled up in a ball. They've got contractures basically from being, stuck in the womb for so long. And so they're all curled up in a ball. And so everything, all of that weight, when you put them on the tummy, all the weight is shifted towards the head and shoulders. So that's kind of where they start working the most because they're having to, try to move against gravity from there. And then as those contractures relax out, they start getting that head control. Then you start to see a little bit more in their trunk and then down into their pelvis. And then you'll see that kind of thing. And that's in all positions. You'll see it, as they get older, the same kind of things, it starts off within, those first few months of life. I mean, within, by the time they're 4 months, you're looking at them, they're pushing up on their tummy and stuff like that. And then, and then the way we develop that control is we have 3 planes of movements that we move in, and that's front to back. We move forward to back first. That's the first movement you're going to get. And then that also extension before flexion. So they're going to use like a lot of that's your back muscles and the muscles that straighten you out and lift you up against gravity. You get those first because you start out in flexion. So you're having to work those other muscles from a longer state, because once you're curled up, then all the muscles in your back are stretched out. So to open all that up, you're tightening up those muscles to open up the muscles in the front. So that's why you develop that. And that's like working against gravity. And then you'll get the side to side. So that's kind of just in this front, like these are, single plane, you're, front to back first, and then you get the side to side motion. And then that kind of will work into more when they start actually moving around a little bit. And then we get into rotation. That's when you actually start to see like transitional movements and stuff, when they start rolling or they start, sitting and reaching out of their base of support and stuff like that. And then also within that, they're going to move. And this is more for like, this actually starts symmetrical and asymmetrical, starts with the, when we say it like head and neck and stuff like that, they're going to move their eyes and their head together first off, and that it starts that young, and then as they develop that a little bit more stability, that's when you'll start to see them being able to turn their head and dissociate their eye movement from their head movement, to where I can focus on something and turn my head away from it and still look that way. And that's how we develop. Everything we do is controlled by our muscles. So even eye muscles, you have to look at that. And then, so you think about like little babies when they're, you see them, they're first laying on their back and they're kicking their legs. The legs are going to typically kick together. You're going to see them come in and go out together. And then as they get stronger in their, core and their trunk and all that, then that's when you'll start to see their legs kicking, separately. And then all of these things you will have to see in that order. And that's in each of these positions. So when they first start off as, itty bitty babies, they're on their tummy and on their back. They've got to develop all of this control in this sequence. And then once they move into sitting, and then once they move onto their hands and knees, then up on their knees, that's, shortening, like sitting on their feet and then lifting up. And then from there, they go into standing. So that's kind of what we look at, with our kids, is that, if we're having a difficulty, where is the breakdown? Is it because, okay, their head and shoulder looks good when they're on their hands and knees, but now I've noticed that when we go and move up into like high kneeling or something, then you're like, oh, wow, now I can kind of see that they're raising up their shoulders and they're kind of holding themselves up like this and all that. So I know I need to start there. So I know that, okay, if we're on our hands and knees, that looks good. What can I do to challenge them there to make that stronger so that we can move to the next level? All right. And then we talked about primitive reflexes. So what is that? This is just kind of a definition of what they are. So if you think about reflexes, these are basically, it's an involuntary movement. And they say it's stereotypic, means you're gonna see pretty much the same type of movement pattern in everybody. And it's always in response to some sort of stimulus or input. And what they're there for is they are these reflexes are a developmental sequence of movement. So that's what we talked about, all those sequences that we go through. They typically start as a reflexive response. And that just kind of helps our body to learn that movement experience. And then it's a precursor to those higher level motor skills. So we'll also get, and that's the thing too, is that when we look at that, you got to think about that all these motor skills are which help our brain develop by developing these pathways, which is going to turn into those higher level executive functioning skills, which is, like cognitive things that we do on a daily basis. And that is done by the body moving through these patterns and opening up those pathways to help send those signals to the various parts of the brain that will that will help that activity dependent learning. And then they develop very early. A lot of these develop in the womb. And then they remain active for the first few months of life, and a couple of them even into the first few years of life. But all that to say, why do we care? What does that look at? And so what we look at that, because obviously these are needed for survival and development in the womb and early, they help us to do certain things that will eventually get taken over by higher levels of the brain. And then they should, as you get older and as you go through those motions and you start doing the higher level functioning, that is voluntary movement, you should start to see those things be suppressed. And then as a child matures, you should start to see them replaced by other reactions and reflexes, and then the other motor patterns. What's important to us though is the presence and strength. So what we look at is, like, if this child has a reflex that should have gone away, that you shouldn't see anymore after 6 months old, but they're 18 months and they still have it. Okay, that's when we know that there's something neurologically that they either didn't go through a certain developmental sequence that kind of would help inhibit that. And then you look at where we can help affect that. Because sometimes these kids can be dominated by that, and you see that it's limiting them getting past a certain developmental milestone. And that's what we talk about beyond that typical age range may indicate some atypical development. And then we're going to talk a little bit more, because I know there was a few questions about this, about just different assistive and adaptive devices and orthotics. So we can talk about, what do you look at for seating and standing positioning. My thoughts on these are just really less is more. But I also know that whatever your access is, if you have access to certain things, if you can, if you need it and you can get it, don't put off getting it just because you don't think you're going to need it long. We've seen kids that have got, like, we work on, like, walkers, gait trainers, whatever it is, stuff like that. We get them and the kid uses it for like 2 weeks and then doesn't need it anymore, but just having that extra little boost of confidence gets them over that hump. And it's, sometimes worth going through a few weeks or a month or whatever of the process of waiting to get it to see them hit that milestone. So when we look at things like that, a lot of this is just going to depend on their level of ability. I want to give them the greatest opportunity to do the most that they can for themselves. And, a big thing with a lot of these kids, when they have that lower muscle tone, is just holding themselves up against gravity. Like I talked about earlier, that if they have that head control, but they don't have that good trunk control, then maybe we need a little bit of assistance there. And we can start there, and that as they develop more, you can kind of back down on the amount of support that you give them. And then, moving from that into a, more standing things and like that. So, and that's when you kind of look at, okay, do we want to get, a standing frame? Is that something that they're going to be using long term? or because it is a lot of those are big and bulky and they're a little bit of a hassle to get them into and out of. But I feel like for most of our SYNGAP kids, though, a lot of them are going to be mobile anyway. So that's not something that a lot of them will need. And then with the mobility, we talk, there's certain things they can use for crawling and then certain things they can use for walking. And some, like with crawling and stuff like that, a lot of that stuff that you can just order online. And there's not a whole lot of like big, bulky, equipment that you can use for that. We use some different things like that. I don't know if y'all have heard of like the Crawligator or anything like that. And that's a real simple thing that you can get for, 20, 30 bucks or something like that. And it's something that just helps them get them up and mobile, and kind of motivates them, because a lot of these kids are going to be mobile. They want to get around, they want to interact with their environment. So trying to get them, to where they have that opportunity to experience that will just usually get a little bit of a boost. And then, like I said, once they do start standing and walking, that's when you're going to look at, do we need any kind of walking aid? And that's also typically when we start looking at orthotics. Once they get up and standing, you're going to look at, again, because they have lower muscle tone, you're going to look at what they actually look like. And what we're trying to do with this is allow them to build muscle, but you also want to do it in the best alignment possible, because then you can be at risk for basically what we call upchain effect, where if our ankles are rolling in real bad or something like that, then what does that do with the angle at the knee and the hip and the pelvis and back and stuff like that? So we've seen a lot of different things with that. They have some off-the-shelf ones that you can do, and that kind of helps just control the heel, and that gets them in a better alignment. But if some of the kids are having a hard time, picking up their toes or something like that, then you may move to a higher, an AFO style or something like that, helps with that, where it gives them a little bit of assistance with, toe clearance when they're starting to walk and stuff like that. So we kind of, again, it's an individual basis, and we'll touch on that if anybody has any specific questions with that. And then, how often should you wear it and stuff like that? I know that's often a question we get. And I'm always the one where I'm going to do it as much as I can without orthotics when we're in therapy, so that I can, work on that strengthening, and, because I can then control, what they're doing at the hip and the knee and the ankle and stuff like that. So I want to be able to see exactly too what it looks like. And if you've always got them in those, they don't have the opportunity to strengthen those muscles themselves. Ooh, that was a lot. All right, that's kind of the gist of it. Like I said, I just wanted to run through it real quickly and get a general idea of what we look at and what kind of questions we were going to have. And then at the end, we can kind of delve more into that and get a little bit more specific.
Awesome. Well, thank you, Ron.
Mm-hmm.
And Ron can take questions at the end if you guys have anything. And yeah, so thanks. And next, we're going to move to Hannah. So we have Hannah Barcelona joining us for occupational therapy. And a little bit about her is Hannah completed her undergraduate degree at LSU in Baton Rouge, OT school at LSU Health Sciences Center in Shreveport, Louisiana, and has been practicing for 6 years. Her husband, Ryan, is a PT, and they did travel therapy together before settling back in their hometown, and they started having children, which they now have 2. And Hannah has taken several splinting courses specific to neurologic and orthopedic diagnoses, and used to make splints regularly before moving back home. So Hannah has worked with Miller, so she has some good experience with working with a Syngapian and creating goals. And so she's an excellent resource for our community. So Hannah, it's all yours.
All right, let's see. All right, can everybody see that? Okay. Okay, so I'm just going to try to do a, like a brief overview of how occupational therapy plays a part in this this population. So just kind of starting out, going off of what Ron said, gross motor wise, you go in a sequence. The development occurs in a sequence. And so kind of like that in regards to fine motor, which is what a skill that OTs work really closely with. A lot of parents ask me why I care how a kid picks up or manipulates smaller objects. And, starting out in infancy, you'd see 4 months, they progress really by month on how you manipulate small objects. And, it kind of might seem silly or nitpicky, but each of these work on specific, strengthening specific muscles, working on specific movement patterns. And obviously it gets harder as the child ages. But the reason that these are important and kind of relate to everyday life are they work to help develop the hands for important things like ADLs, which are activities of daily living. So getting dressed, being able to button buttons, manipulate zippers, either Velcro or tie shoes, whatever the child is using at that time. Just really being able to develop those manual dexterity and fine motor skills is something that we work really hard on because it kind of relates to other things later on in life. Even down the road, you're going to want to have, decent strength in your hands, whether you write with a pencil at school, whether you type, or, some kiddos who use AAC devices, you still need to have like fair finger isolation, manual dexterity, fine motor control, which is why, we look so closely and detailed into this area. I know it's a lot. If you have questions, don't hesitate to ask at the end. Be happy to answer them for you. Going back into that, grasp is just important for the relation to ADLs. So strengthening the intrinsic muscles of the hand. So all those small muscles in the hands, separating the two sides of the hand. So being able to separate one side from the other is a really important skill for ADLs, for academics. And like I said, finger isolation. So being able, use a cell phone, use a calculator, use an AAC device, anything like that. So we work really hard on fine motor skills and that's why, right there. Okay, kind of shifting gears here, talking about sensory processing. This is a very, it's very complex. I could spend a very long time breaking this down. So I'm going to try to give a brief, kind of educate y'all pretty briefly on this. So sensory processing is just the way that a child takes in sensory input from the environment, noises, textures, feelings of things, visually, like whether they, are sensitive to light, noises, things like that. And a child with low registration here, the top left, so they don't respond to loud noises. They don't respond to a lot of, bright lights. And so they can kind of seem as like standoffish. They're not meaning to react that way. They don't on their own, seek out more sensory input to try to meet their needs. So their threshold is pretty high. They need a lot of noise, a lot of, sensory stimuli to be able to register for them. The opposite down here, the bottom left, are those who are sensitive to sensory stimuli. So their threshold is low. What doesn't even register to the child with low registration, it's very, very overwhelming to the child who is sensitive to sensory stimuli. And again, the reason that this is hard is that, the child and the parent at first, they don't recognize what the issue is and how to resolve it. Sometimes these kids may present with, outbursts, behavior outbursts, meltdowns. And to the parents, to you and I, we might not understand it. And they themselves at first have a hard time understanding it too. So OT can kind of just help by jumping in and figuring out you know, where this child is having problems processing sensory stimuli, and kind of help them make modifications in order to make them the most, you know, able to function the best that they can in their environments. Sensation seeking is, you know, it's just kind of the opposite. These kids actively try to gain more input. So these are the ones that like to swing, that like to slide, that like to jump. You know, for some people that's tiring. For kids who seek this information that regulates them, for some that even calms them. Sounds silly, but like getting energy out before bed, like that's a thing. Some kids need this regularly throughout the day. Some kids need this to complete a single, you know, 20-minute task. They might need several breaks in that time period to be able to go swing, to be able to jump on the trampoline, get some proprioceptive input there. And then sensation avoiding are those that, you know, just simply avoid crowds, avoid lights, avoid sounds. Modifications for that group are maybe giving them headphones, and they make, you know, they have the large ones, but they even make smaller ones, you know, for some who don't like to stand out as much, but like to be able to control the noises in their environments. And those are, again, just very, very brief examples. But OTs can skillfully observe how a child is functioning in their environment and provide modifications, recommendations to help them function most effectively and appropriately for them. And like I said, some kids who have trouble with their sensory processing systems come off as, you know, it being hard for them to control their behavior, like negative behaviors, outbursts, things like that. And it's just not intentional. It doesn't always have to be intentional. So they're just having trouble regulating these stimuli in their environment. And OT can help largely with that. Again, let me know if you have any questions on that. So kind of going back, you know, Ron was talking about you know, strengthening in different positions, different planes, and also the importance of early intervention. So especially with early intervention, early on, ages 0 to 3, PT and OT can overlap at times, you know, working on gross motor milestone, attaining those, and even strengthening. But an OT looks at strengthening a little differently. So why do we want to strengthen the upper extremities? So that they can, you know, improve their independence with donning a shirt, being able to put a sock on their foot, provide enough strength to pull it up over their heel. And these are just examples, but strengthening of the hands, so fine motor grasp, being able to button a button, push a snap closed. So, you know, some kids have the coordination and the fine motor skills to do so, but they might just be lacking in strength. So, you know, we strengthen with meaningful activities in mind. And so same thing, specifically as it relates to academic performance. So core strengthening. So a child with a weak core, if they're sitting at a table or, you know, wherever they complete activities, wherever they complete academic tasks, whatever it is that they might be working on, sometimes kids prop, sometimes kids lean. So a lot of that is weak core. So working on strengthening the core for those reasonings. And again, if a child, you know, kind of like Ron mentioned, the plateau. So if you work on strengthening and you're still seeing these issues. So OTs can recommend modifications. So kind of going back to dressing, you have dressing sticks, you have sock aids, you have adaptive clothing, button hooks, things that can kind of help be independent, even if your strength does not get to where you want it to be. Same thing for upright positioning and posture. You know, we can have supported seat backs, advanced foot support, special or, you know, chairs sized specifically for the child, just to promote most support. And again, with independence in activities of daily living, which is bathing, dressing, toileting, grooming, brushing your teeth, and also anything that is important to the child and their caregivers is considered an activity of daily living. And everything that OTs do is just with that in mind, wanting them to be the most independent, have the best quality of life as possible. And with all of this being said, everything that I'm talking about, each child is different. What might work for one might not work for the other. So OT at times can even be kind of trial and error. Like, okay, these are the symptoms that I'm seeing. These treatment methods have worked in my experience in the past. Well, the caregivers come to me and they say, but this just isn't, we're not getting to where we want to be. We're not meeting our goals. Okay, so let's kind of take a step back. Let's regroup. Even if it worked for a kid somewhere in the past, it might not be working for this child. And there's other routes, other ways we can move forward to help them reach those goals. So other, kind of going along the lines of modifications again. So, and creating the greatest level of independence. So we have this to-do list here. This one is a specific, this example is an OT schedule. So like if a child comes to OT, this is everything that we want to do. This is everything that's done. Once we do it, we check it. You can use these for morning routines before you get out the door. You can use these for bedtime routines. Children can use these for their chore list before they get their iPad, before they get, whatever reward it is that they might be working towards. So that's a good visual modification kind of sheet that we can use there. And I know a lot of our kids are, working on kind of, being able to express themselves. A lot of kids might feel mad, but might not know what mad is, might not be able to recognize that and react appropriately. So, visual images, like this child is happy, this child is sad, has the frown face, and, just any visual cues to help a child learn emotions and, maybe being able to recognize I'm sad and get so that someone can help them, so that we can gain something from knowing what we're feeling and come over the hump with that. This last one over here, it's just another example. So you'll see the box on the far right. How I use this when I'm practicing with children is over here. You put a picture of maybe their favorite thing in the OT gym. That's what they want to do. That's what they're working towards. So they have to do these 5 things and then they get this, and it's just a good visual reminder. Some kids might need a downgrade. Some kids might need to get 1 star and then do this, another star and then do this. Some, higher level can do 5 things and then get their reward. And these can be as complex or as simple, like, as you want them to be, just to make the child feel like they're completing their work, feel successful. You can do that as a way to help a child feel successful, or for kids who, might have some behaviors that might not want to, or might have a hard time working on the harder things. Just use it as a good way to positive reinforcement, make them want to engage in what you're having them do. So this is just kind of a recap. Again, an ADL is something that's meaningful for a child, and what might be meaningful. So Julie kind of gave us the example. Miller, he just doesn't have interest in riding a bike. And so it wasn't important for them. So, while that might be a skill that one child wants to learn to master, Miller has his other things that are most important to him. So, it's just, we work on strengthening, we work on all of these goals, but in an individualized pattern, to make the child most, successful in their day-to-day life. We work on skills such as attention, sequencing, working memory, fine motor, sensory processing, and all of those, again, just kind of relate to dressing. So for example, sequencing, we have to first orient the shirt, and then we put in one arm, the other, and then we pull it over our head. Sequencing is a skill that has to be learned too, and it's harder for some kids more than others. So we can work on that too. And we address behavior that is and is not directly related to sensory processing. So, some behavior can be intentional. Other behavior is not. It's just as it relates to a child's inability to deal with all of the sensory stimuli within their environments. Again, strengthening, unique modifications, and then let's see. And, Ron touched on this too, but early intervention is crucial. Neuroplasticity is most constant and rapid from birth to age 5. So early intervention, PT, OT, speech, is just it's just most effective during this time. It's when a child learns the most and the best. And 2 times a week is most common. I know in the schools it's a little less than that, but as a child ages out of early intervention here in Louisiana, it's called early steps, ages birth to 3. Each state is different. But when they age out of there, they can get services in their school, in their public school. But they can also still attend an outpatient setting to where they can come 2 to 3 times a week. And, you don't just have to do one or other. You can also get ABA on top of that. There's other services out there. And it's true, the more the merrier. Like Ron said, a child can get burnt out, and it's our job to recognize that and be like, hey, let's take a break for a little while. But just because your child is getting one service in one setting, it just know that it's not limited to just that. And kind of like I've touched on, goals they're always changing. What might be a goal for one child, the same age with the same diagnosis, is probably not going to be the same goal for another child. And as a child ages, these goals change. As a child reaches goals, these goals are to become harder, or to promote continued development, continued progress. So we're here to help these little children, and it is our job to see their skills, observe their skills, hear parents' concerns, and kind of just wrap all of that up together and form a plan of care that the caregivers are involved in, the children are involved in. And also it's important for OT, PT, and speech to work closely together. And if a child gets ABA, we do our best to communicate outside of our clinic too, and just to make sure everyone's on the same page, promote carryover. For me too, and I think most therapists create home exercise programs as well. So, bringing parents back, educating them on exactly what we work on, and creating a handout for them to have exercises and activities to practice at home outside of our sessions as well. And kind of all of that together is where you're going to have the most carryover and the most and the quickest progress. But that's all that I have right now. So I look forward to hearing your questions after Morgan. Thank you.
Thank you, Hannah. We appreciate that. Super helpful. I wrote a lot of notes down myself. Just it's good reminders, especially for us, just the behavior aspect as our kids get older. And so that's something that I wouldn't be surprised if you got a question about that. So, just very good stuff. So thank you, Hannah.
Thank you.
Okay, last we're going to hear from speech. We have Morgan Kumler here. And again, Morgan has worked directly with Miller. I think we worked together maybe post-COVID. Is that, I think when Morgan,
Yes.
was that when you joined in with us? So, and that's around the time Miller got his AAC device. And so Morgan was very, just on board with getting him started on that. And anyway, that's just where we got started with our AAC. So we're so very thankful for you, Morgan. All right, so Morgan received her master's in speech therapy degree from Louisiana Tech University and has been a licensed SLP for 5 years. She's married to Brady and is mama to Cassidy, who is 19 months old. We got to see her just a few minutes ago.
He was going to sleep.
Oh, sweet girl. Morgan is passionate about early intervention, play-based therapy, and treating pediatric feeding disorders. Morgan completed training last year on the sequential oral sensory approach, or SOS approach, to help children who struggle with eating from an oral motor skill-based or sensory standpoint. So that's a mouthful.
I
All
know.
right, Morgan. Well, you can go ahead and get us started on all things speech, and we are all ears, trust me.
Okay. All right, let me share my screen here. If I can remember how to do that. Okay. You see everything? Okay. So speech is a huge umbrella, as I'm sure y'all know. And so I tried to pick basically two major things to discuss today, feeding being a concern that Julia had brought up. And then later I'll hit on some speech milestones as well as some AAC based on some questions that we had. And of course, if I don't touch on it, ask away at the end. I'd be happy to answer your questions. So let's dive in and I will try to keep it brief. Okay. So let's start with feeding. I hope you don't mind, but I stole this percentage from your website. Did you know 68% of children diagnosed with SYNGAP struggle with eating? What? That's a huge percentage, y'all. So this is why this is a big deal. Okay, but let's get into the nitty-gritty of it. It's a myth. Feeding is not a two-step process. It doesn't involve just sitting down and eating. And if you have had a toddler or have a toddler like me, you know that that is not the case. Whether you are typically developing or neurotypical, it is not a two-step process. There's so much more to feeding that is under the hood. So let's dive into that. So feeding is the tip of the iceberg. What's underneath? I'm going to kind of talk about some of the things that even Hannah and Ron touched on. So when we look at feeding, we are also looking at the importance of our organs and our muscles. So organs, we kind of want to talk about, does our child struggle with GERD? Do we have constipation issues or other GI related issues? Because those can affect a child's success with eating, as well as their muscles. If a child, I feel like most of our SYNGAP population struggles with low tone, and that definitely does play a role in our ability to eat successfully from an oral motor standpoint, but also a postural standpoint. If we're not able, like what Hannah was saying with our trunk control, if we're not able to maintain our support at a table and activate our core the way that it's supposed to, we're not going to be a successful eater. If we're like flopping over in our chair, our head's not going to feel supported, our brain's going to go into fight or flight mode, like, oh, I need to protect myself. So referring to PT and OT as a team is very important for this. I steal a lot of their stuff, like their seating supports, their steps, all the things to help my kids in the session be as successful as possible with their support. Also touching on a little bit of what Hannah talked about, the senses, like the sensory system. So eating involves 8 total parts of our sensory system. So sight, taste, touch, hearing, smell, the vestibular system, proprioception, so understanding where your body is in space, and then interoception, like the feeling of knowing what's happening in your body, like the feeling that you need to use the restroom or the feeling of hunger. I believe one of the questions was related to like G-tube feedings. If a child is continuously on a feed, how are they ever going to establish hunger cues? We don't think about that. us who are, typical eaters, we know that, okay, 9 o'clock, my stomach's going to start growling. 11 o'clock, I'm really ready to eat. And then 12 o'clock, I'm ready for lunch. My body has a set schedule. I'm in tune with those cues. I've developed hunger cues. But if our body never receives those cues, how do we know what hunger feels like or fullness feels like? So we'll dabble into that a little bit more if others have questions related to G-tube and stuff. Okay, next, our learning and developmental skills. So where is a child and their ability to learn? Are we in a sensory motor phase? Are we a concrete thinker? Do we learn from tactile cues? Do we learn from auditory cues? Everybody's different. So you kind of have to play into how that child responds best, how they learn the best, and then also meet them where they are from an age appropriate developmental standpoint. I hope that makes sense. Okay. And then nutrition is a big role here. So important to be, in tune with your, not in tune, but in communication with your child's pediatrician. How are we on the growth curve? Are we below where we should be? If so, okay, what can we do to get some adequate calorie intake? If we have calorie deficits, then, maybe we might be too weak to eat. If we have certain vitamin deficiencies, then maybe our appetite is suppressed, or maybe we might feel hungry all the time. I don't know. Everybody's body's different. So just making sure that we have the appropriate nutrients. And then lastly, environment plays a big role in feeding. So think about presentation of food or positive reinforcement at meal times. Limiting screen time at meal times. Ouch, because I'm so guilty of that too. I'll sometimes put a screen in front of my kid just to have a little mom moment. So we'll talk about that. If anybody has questions about screen time too. So anyway, as you can see, eating is very complex. It's not a two-step process. There's so many things that have to go together for your child to be a successful eater. So, all right. I put down some oral motor milestones just because from a skill-based standpoint, this is very important. If our child does not have the skills to eat, then how are they going to be adequate consumers, And so from the time of birth, we have certain reflexes that we are born with, and then those reflexes start to integrate. And then naturally, our brain just kind of is awesome. It figures things out. And so our tongue starts to develop certain movements, like from 7 to 10 months, that tongue lateralization, that's the side-to-side movement of our tongue to help sweep the food back to where our molars are. And then from there, we're going to swallow. So we can't swallow food from here. We're not going to be very successful. And so with our low tone kids, we might see food kind of scattered across our tongue. Maybe we gag. Maybe we don't know how to spit it out. We'll talk about here what immature oral motor skills may look like. And so having difficulty with chewier foods like steak, chicken, bread, all of that stuff that's really hard to chew, or even extra crumbly foods like chips, things that get lost in your mouth. Maybe the child has difficulty, like I said, sweeping it to their molars. It just kind of falls there. Maybe they use their hands for assistance. I see this a lot, especially in our younger populations with feedings. If you're using your hands, probably I would say past like between 1 to 2 years, then maybe our tongue isn't doing its job. It's okay to use your hands if something falls out, right? Because that's just natural. Even we as adults do that. But if we're constantly using our hands for placement, our tongue's probably got some weakness. Maybe we got some loss of food or drink. Like I said, maybe we're gagging, coughing, having frequent choking. And then maybe we get tired. Maybe feeding just really wears us out. So all of that also kind of plays into just overall low tone. So SLPs can help. Yes, we can skillfully assess your child's oral motor skills at evaluation and recommend certain strategies or exercises that you can do at home. You can see my friend over here on the left. We do a lot of oral motor fun in our sessions. It doesn't have to be so rigid. It can be fun. And he's a teenager, so we like to have fun. And so also, if a child, if they have swallowing concerns, SLPs can offer neuromuscular electrical stimulation. So you might have heard of VitalStim or AMP Care. If your SLP that you see is trained in those areas, then they can offer that to help strengthen certain pharyngeal muscles or any muscles that are specific and weak to what your child is going through. Make sure the SLP is trained in that. You don't want just anybody putting neuromuscular stimulation on your child. So, and then also very important to collaborate with OT from a sensory standpoint. I've had some knowledge in it, but truthfully, I learned so much from Hannah, and I've learned a lot from our other OTs that we collaborate with. And then too, from physical therapy, especially with core stability, it really all goes hand in hand. Our body is such a unique integrant system. So to have your team collaborate is like, that's top notch right there. SLPs will also, usually in their evaluation, make referrals to appropriate professionals like ENT, pediatric dentists, in the event that your child has any tethered oral tissue. So tongue and lip tie, buccal ties, things like that. Kind of a gray area in our field. So you may get one speech therapist say one thing and one speech therapist say another thing, but you're the parent, you know? If your mama or daddy gut says do something about it, then do something about it, but also take the recommendations as well. And then, as I said earlier, make sure that you are communicating with your child's pediatrician, or if they have a nutritionist or a dietitian on board, to make sure that your child is getting adequate nutrition, is getting the appropriate amount of calories, so that they can be a successful eater and then just grow the way that they're supposed to. So, okay, cool. That's feeding. In a nutshell, that's very brief. So like I said, if you've got more questions, it's kind of my jam and I would love to answer. So, okay, let's talk about communication. All right. Here are some, what I would call early warning signs to pay attention to determine if your child is showing some speech or language delays. So minimal to no babbling. Maybe your child isn't using gestures or any sort of vocalization to request or just interact with you. Your child may have difficulty understanding what others are saying. So maybe some difficulty following commands or kind of some object disassociation. We may not understand the purpose of something. Difficulty putting two words together or imitating sounds. I know that Julie, you had mentioned apraxia of speech is a big umbrella in this diagnosis. And I was going to touch on it, but again, it's kind of, there's a lot under the surface of that. And so if you've got questions about apraxia of speech, please let me know. I would be happy to talk with you about that. But in order to keep the presentation brief, we're just going to continue moving on. And so how will your child communicate? Once we have done our initial evaluation, you know, depending on their skills, maybe your child is we're going to work on speaking, like using our actual voice to speak. Or maybe that's hard for us, like a child with apraxia, for example, or any kind of motor planning problem where we cannot formulate those sounds together. Maybe we're going to use another alternative to speak. Maybe that looks like sign language or using technology to aid in our communication. So let's talk a little bit about AAC. Lots of options here. Here are some what I would call low tech options. So sign language being one. We use Sign with Miller. I will never forget the sign for cracker because of Miller. I feel like that was his go-to for all of us. And we all knew that whenever Miller said cracker, he gets that cracker. So, and then the red buttons here, these are switches. So you can plug these into certain toys. You can record your own message. They're very simplistic. So usually one message at a time can be recorded, unless you have a switch option where there's like multiple recording settings. Anyway, we'll get into that. And then picture exchange communication system. Again, kind of a gray area in our field, especially with our neurodiverse population. I feel like some people fear that maybe it's asking, like we're forcing a child to communicate on something they may not want to. But I'm going to hop on from where Hannah's standpoint was from using a schedule or a choice board. I feel like you can give your child a lot of freedom to communicate and make a choice by having desired options already printed out on a picture or a board like that to make a choice. We use that all the time in our sessions. Okay, then we've got some mid-tech devices. This is the Go Talk Buddy. Now, this device, basically how it works is you have set icons that you choose for your child, and each individual icon can have a recorded message. And so whenever the child activates it by touch, it says that message that was pre-recorded. So like Hannah was saying, fine motor dexterity and strength, big proponent for this specific device. Not saying this is the end all be all. And there's also devices like this that have less quadrants, so it's a little less overwhelming. There's some as little as 6 options, so lots to choose from that. And then we can get into high-tech devices or what we would call speech generating device. So this looks like a lot of electronic stuff. The cool thing about high tech is in this day and age, there's usually an app that you can find, whether free or by subscription. You can find some apps even on an iPad. A couple of apps that I use that are free. I didn't write them down, so excuse me, I'm looking at my iPad right now. I use one called Visuals to Go, like visuals, the number 2, go, if you want to write that down. Some that require a subscription or a purchase up front include Touch Chat or Proloquo to Go. I've seen kids have a lot of success with that. And sometimes, I'll be honest, the apps can get kind of pricey, but I guess from a parent standpoint, if it were me, you can't really put a price on communication. It's so important. But if you need financial assistance, you can always see what your insurance company is willing to buy. And not only that, like what Ron, I think, was saying about the school being involved, schools can also fund your child a device. And so if you contact your school board and get your child on an individualized education plan, have them evaluated, that can be something that can be done through the school board. And I don't know if it varies by state, but I know that the children that I've worked with have their own personal device. Like the device comes home with them. It doesn't just always stay at the school. So that's really great. Julie, I know you had mentioned there was a question about a sibling possibly wanting the joy of having an AAC device too, so they can be like older brother or older sister. And I love that. Oh, that's so awesome. Okay, here's the thing. I think the best way to approach that, mom or dad, if you're watching, is to let little sibling know, like, hey, this is so-and-so's voice. You know how you talk to him or her? This is how he or she is going to talk to you. Isn't that so cool? And guess what? You can even be a special part in that and helping them talk. You can show them where certain icons are. You can show them how to say this message. Isn't that so awesome? This is just for them. It's so great. And we want to reward any communication attempts that we get from that. So if I need to touch more on that, parent who asked that question, you just let me know. Okay, real quick, I'm going to breeze through this. How do we implement AAC at home? Because I know, like, outside of the therapy setting, how are we going to make this happen? So, okay, first off, become familiar with your child's device. The more comfortable and familiar you are with whatever system you choose to do, whether that's sign language, whether that's a low-tech device, that high-tech computerized device, the more you as the parent dive into it and figure it out for yourself, the more you're going to feel confident in helping your child use it. So, and then also we're going to provide examples for communication. Your child is not going to know how to communicate unless we show them how. So that may look like setting up specific scenarios. Maybe it's mealtime, or maybe it's a specific toy that we like. And so AAC is kind of a cause and effect scenario in a sense. And so in order for a child to know, like, this is my voice, we have to show them the effect of using it. I hope that makes sense. Next, keep communication accessible. Make sure whatever form that you use is available at all times. If this is their voice and you put their voice in another room, how are they going to use their voice? You tell me how they're going to use it. So, okay, next, use core vocabulary first. These are basic vocabulary words that aren't fringe, or they're not situational. They're words that are more like go, stop, all done, please, more. Things that are really going to get their needs met immediately. And then as they grow in those skills, then you can start adding more of those fringe type vocabulary words. Okay, and then provide opportunities to communicate. So what's important to your child? What do they like to do? If they like to listen to a specific song, okay, well, maybe we have our icons ready and we're ready to I'm like trying to think of a specific song. Let's use Brown Bear, the book, as an example. Maybe we have the Brown Bear icons on our device, and that's their way to participate with reading. I had a little 2-year-old girl who loved that book, and that was one of the first fringe vocabulary sections that we started to work on. Was as we went through each page, she would select the specific icon for that animal, which is really cool to watch. Okay. Lastly, your child has a voice. Whether they are non-speaking, it does not mean that they are non-feeling or non-thinking. They have a voice, and you are their advocate. If they're not able to verbally advocate for themselves, you are their advocate. Give them a means to advocate for themselves. Ask the hard questions to your speech therapist. There are resources on the internet where you can look and see what your state guidelines are for accessibility to AAC devices, what your insurance company covers. Yeah, it's important to remember that. So your child has a voice. You are their advocate. I'm just gonna hone that in right there. That concludes my end of things. Julie and everybody else at the SRF group, we thank y'all so much for giving us this opportunity, and I hope each of you know that we at Melanie Massey are here for you to answer any of your questions and to be your support. So thank you.
Thank you, Morgan. Oh, you just had to add that at the very end, making me tear up over here. But thank you for that reminder. Really, that's great. Okay. So Lauren, I think I can figure this out. We do have some questions. So if y'all want to send some more in, as long as you three have time to answer.
Yes.
let's see. You guys may be able to see them in the Q&A, but Megan has a question. She said, so I see a lot of 2 to 3 times a week. We only get 1 time a week for 30 minutes for speech, OT, and PT. We only get 60 visits a year. Which insurances are covering 2 visits a week? So if one of you wants to answer that. We personally ran into this very same thing. So if you guys want to cover it, maybe from like your standpoint of what you're seeing that parents are doing in order to get more visits, appealing, or if they're using if they've got a secondary Medicaid or something else. What are you guys seeing?
That was going to be my first thing, is that, we have, a lot that do have Medicaid as a secondary. What they've recently in the past couple of years implemented here, and I don't know if it's, a nationwide thing or if it's just a state thing, but, and I can't remember what the acronym stands for, but it's TEFRA. And so there, where Medicaid used to be income based, we now have medical necessity. So it's possible now for children who have specific diagnoses that are going to reach, basically they qualified because they are going to need continual care of some sort. And that's a way for them to qualify without having to be low income. And that's been helpful to a lot of ours. And we've had some of those with Medicaid that have actually gotten 2 times a week. And a lot of that depends on documentation from us. That's a huge part of that, very well, Julie, that we have to document medical necessity, and we have to document the, show proof that we're actually making progress in our sessions, and that there is also still a need. It's a fine line to say, yes, we're making progress, but however, we're not where we need to be yet. And so that's something that's, on us. And I feel like there are also other options out there as far as nonprofits and stuff like that that do help. And then some places offer, cash pay services at a discount. And that, helps as well. That's what we do here. But we do have, I know it said, what insurances are covering that. It's a variety of them. I think our biggest success that we have is actually, surprisingly, the government insurances, TRICARE, which is through, for military families, and then our Medicaid ones, actually, that we're able to get 2 times a week for.
Yeah, it sounds like there's a hard limit on the specific insurance. So I think your team is trying to maximize the amount of times that they can see your child. So that 60 visits is spread out between 52 weeks in a year, which is tough. So what Ron was saying about Tefra, I'm going to respond in the chat with that so you can look into it, Megan. And hopefully you'll be able to see my response.
But correct me if I'm wrong, but I know sometimes for rare occurrences at our clinic, whether it be an insurance is approving fewer visits, or simply like the families are traveling from far away, they can't make it twice, 2 or 3 times a week. We sometimes increase the length of the session, because one session is one session. So maybe you could ask and see if while you're there, if you could do more than 30 minutes at a time. We increase our typical sessions are 45 minutes. We will see them for an hour or more sometimes for unique cases, to make sure that they're getting all that they absolutely can, without driving crazy hours or running up their visits with shorter sessions.
I agree with that.
Yeah. And then Megan's also saying that they did do we did do the public school, but they came once a month, but did mostly just ask what I was doing, not much help. So Yeah, that's tough because the public school is sort of a whole nother ball game, and
Yeah.
every state is completely different. We've had great um, we've had great care really in Louisiana, but Miller was still real little, and then here he gets more than I ever thought he would get. He gets quite a bit in the school system. So I don't know how you guys want to answer that because it's just so different every state.
Yeah. What I've seen here too is because we have a facility that we contract with here that's it's like basically a nursing facility for pediatrics, and it's just a daytime program that they have, and they have to have nursing needs to qualify for it. But our local school system provides services for those children. And what we've seen is that they, a lot of times, like you said, it's like the PT is more on a consult type basis, to where they are in there once a month, because we have one therapist for the entire school district, which is insane. But we have a good adaptive physical education instructor who comes in, and they work hand in hand with the physical and occupational therapist to kind of help. And they come in on a weekly basis and see each one of those kids once a week. So that's something extra that those kids are able to get. And I don't know if all states have that, or all school systems, but that's kind of what we saw there. Speech, our kids in the school system don't have any trouble getting speech. Those I feel like they have pretty much one school or one therapist per school. And I'm not sure, I guess because they regard communication higher, and their standards are. And I saw another question, and since we're on that, I'll touch on that too. It said, could we touch on medical versus educational model eligibility? And I may need some clarification on that. What I'm thinking of is that, how do they qualify for school therapists versus, outpatient services? And for ours, I know that the standards for school here, like for them to qualify, are much lower. So sometimes it is harder for them to qualify for those services in the school, where we may see a need, because we're looking at their whole life and not just, can they sit and attend in a classroom and not disrupt the classroom. So that's the difference that we see here locally. And again, like I said, if that's not specifically what you were looking for, please feel free to get give me a little bit more clarification on that so that I can address that one better.
Yeah, Megan, you can talk if you want, or if you don't, that is okay.
I don't know what were you wanting me to talk on? Sorry.
Megan, do you want to ask a little bit further about the insurance possibly?
Oh, yeah.
Or someone did make
I-
a good comment about units versus actual just sessions. Like if they're limiting how many units you can have, or how many just sessions you can have, or visits, excuse me.
Yeah, you've explained it. We haven't gone through the paperwork yet for Medicaid, so that makes a lot of sense. We've also started ABA, so I'm more wondering like if we can, we've incorporated a lot of speech with the talk device. I've pushed a lot for that with them to do during ABA. But just we have already signed the forms so that they can share and communicate with each other. But how do I communicate? What's the best focal points to focus on to see if ABA can do certain strategies, OT's doing, PT's doing, speech is doing, without upsetting one or the other, if that makes sense?
Oh, yeah.
Sometimes it's struggle with communication and stepping on toes.
I know from personal experience with that. I feel like a lot of times it starts on our end, that we want everybody who's involved with the care of the child to be on the same page. And so a lot of times that we have to initiate that conversation. So I feel like it may be, if it's in your situation, whatever you have, whatever, whether it be ABA or one of your therapists, that you have the best relationship with, broaching that with them. And if they are more open to that, it may be easier to get them to do it from a professional level. Because again, if ultimately anybody who's caring for your child, that should be their ultimate goal, and their priority is what's best for the child. If I'm putting my pride above what's best for the child, and what your desires are for your child, because ultimately that's, I think that was one of the questions we talked about too before that somebody had sent in earlier, was what are the goals for the child. I think each child needs specific goals, and I feel like if there's anything that can be done on both ends to address those goals and help that child to, reach those goals, then there should be open communication amongst all parties.
I agree. Just sometimes you run into those very few that we've been doing pretty good with communication, but there's some parts. So.
Oh yeah, absolutely. We run into that more so probably with physicians. We have a local Shriners hospital here, and getting communications from them is, we're never going to get stuff sent from the doctors because they're so overwhelmed that they don't have time to initiate that communication and conversation. So I know we always have to reach out, and so there's certain aspects of that we know from our end that that's not something that we're going to hear from a physician on that. And if you do have a disagreement, ultimately, I always just tell the parent, this is my opinion on this. This is why I feel this way. I try to see it from their point of view as well. And so this may be why they're saying it this way. But ultimately it's your choice. So that's how I was like, we always have to, defer to the parent. We can educate you, and we can give our, educated opinions, but ultimately as a parent, it is your choice, and you're going to hopefully be able to make the most informed decision based on that.
Megan, I wanted to add before you, I don't want to take away your time if you have more questions, but I wanted to ask, can you get more at your IEP meeting? I don't know if y'all are going to meet again when school starts or not, but ask for more from more visits from OT and PT and speech. If you're getting all three at school, if you want more, which sounds like you do, and I would too, you can always put that in the IEP.
Well, she's only 2.5, so she's still at home base, so they would only send out an OT that worked on PT and speech also, kind of. So it was kind of just frustrating. So we just ended services because we switched to ABA, and we were getting a lot more direct services that way for now. And then we'll see if we go back to the school system, but the school system she's in, I worked in the school system for PT. They only do they just check in them 4 times a year. Speech is just non-direct, and so it's really hard to fight that system when they have some of that. And OT was also just 4 contacts per year.
Gosh, I'm sorry. What state are you in, Megan?
Nebraska.
Okay. Alrighty.
So we're trying to do a lot more private insurance paid.
Yeah, well, I hope that works out for you guys. And if you have any more questions, if you have any more about like the Medicaid program, if y'all have TEFRA, I know Morgan helped you a little bit, but we also have TEFRA in South Carolina, and it has been a game changer for our family. I mean, it just, the floodgates opened up after we got that. So I'd be happy to talk with you if your state has that and you have questions.
Yeah, I'm definitely looking into that.
Yeah, yeah. And
Yeah.
it's a lot of states have it. It may not be Tefra exactly, but it's similar to
Mhm.
Tefra. So,
Awesome.
Nancy had some questions.
She wants to come on, she can.
Yeah.
Okay, I
Or-
think you can hear me, hopefully.
Yeah.
Okay, great. Well, thank you all so much. This is really quite educational and so helpful. I did want to ask Morgan also a question about the AAC evaluation. Like if a parent feels as if their child might be eligible, might not be eligible, but they're not sure, how do they even go about starting that whole process?
That's a great question, Nancy. I feel like it does kind of look different for every child. For me, what I've done, if the parent has brought up concerns or an interest in AAC, I try to access devices that differ in strategy. So I take those devices, they're all different, and I see which one would best benefit the child based on, their fine motor ability or their cognition, their language skills and their attention, and also their memory skills, because, some devices, they require a little bit more navigation than others. Um, for me, I have some pinpoint people in our state that I contact as a speech therapist, and I try to access devices that way. There is a child, like I don't know if you've heard of Toby Dynavox. There was a state representative that I contacted to get a device shipped to me just for an evaluation, and then I returned it. It was really great, just to determine if that specific device was appropriate for that child. So what you can expect during the evaluation is hopefully the speech therapist will trial some different things. But a lot of the times in my treatment session, if I've got a means to just implement it here and there in treatment and it's successful, I'll let the parent know and we'll kind of jump on that way. So most of the time I'm already kind of dabbling in it in our treatment sessions. But if you are interested in seeking out AAC evaluation, I would definitely talk to your speech therapist and see if you can get the ball rolling on that, because it's awesome.
I think all the families would like to clone all of you right now.
Oh, mercy.
I agree with that 100%. I even told the lady that owns the company, I was like, you should open one in South Carolina. So, yeah, this has been great. Does anyone else have questions? I don't see anything in the Q&A, and I don't see any. Laura may be able to tell if someone's raised their hand, but I don't think anyone else is out there right now. But if you guys do have any more questions later, oh, there is something for Morgan, looks like. Yay, let's see, Laura. Oh, Laura's letting Megan know that there's something out there. Good. And then let's see. Gasper, I hope I'm saying that correctly, has something for Morgan. So Morgan, if you want to read that.
Yeah.
That's a good question.
Yeah. Whew,
Mhm.
okay. I hope I can touch on all of this. Okay. So you've been receiving speech therapy over the last couple of years. Not enough emphasis on the oral motor planning and enunciation. So I think from that standpoint, going back to communication preference, what is the goal in therapy? Is if the goal is for your child to be able to articulate, and there is an oral motor issue, then the SLP would hopefully be addressing that. And then two, if there is some oral motor concerns, I would request for a home exercise program to be given each session or at least one time weekly. So that way there can be even carryover to promote success at home and outside of therapy. Let's see, practicing bilabial sounds, but no exercises. Yeah, so going back to being your child's advocate, there's never going to be a wrong time to ask for resources from your therapist, any of them, PTOT, speech. So if you feel like more needs to be done, then I would for sure address that with your SLP. I hope that I answered all of that. And if I didn't, Jasper, please let me know. I want to make sure that I'm understanding your question. Let's see. I want to push our SLP further, but I feel like I don't have the right language to request what I think we need. Okay. And that's hard because confrontation can be a little difficult. But I think the way that you worded it just then was perfect. I mean, because I feel like I understood it. And you as a parent, as long as you're saying, hey, this is my concern, I'm not seeing progress in this area, what can we do to help fix this or help my child be more successful in this? I think as long as you're communicating just that and your speech therapist knows exactly what you're working on in the session, he or she will be able to help you. Yeah, I don't feel like you'll be pushing your SLP. I think you will be doing your child justice and asking for those additional resources. So just know that there are pros and cons in the confrontation side of things, but from an early intervention standpoint, just go for it. The SLP is going to help you.
I agree. I mean, we all as therapists want the best for our
Yes,
patients. And
absolutely.
then just as
We
on the
like-
mom side, like you're with your kid the most. I mean, our therapists, we're
Hmm.
with them for just a few minutes out of the entire week. And so
Oh, yeah.
if you're not seeing much carryover at home, it's definitely
What's
a
the point of
conversation to
therapy,
have.
you know?
Yeah.
Yeah. Right. And that's that a lot of that falls on us because if we're not educating parents on why we're doing what we're doing and how, then how are they going to be able to carry it over home? Like you said, we get just a few minutes a week. In some cases, you're looking at some of these parents, 30 minutes a week is, if that's all insurance is allowing, that's, I mean, very minuscule. So I feel like in the situation like that, a lot of that time should be spent educating.
Yeah.
So that, and working towards what can you do at home. It goes back to, like I said, but in the very beginning, if you had a child who was in some sort of sports or any kind of competitive thing like that, and you want them to excel in that, you're going to take that time and spend it doing with that. But if their coach isn't helping you to do the things the correct way and giving you things, okay, this is what you need to be working on at home and stuff like that, then they're not going to excel. And again, I always take it back to, this is what our children need to get to a higher level. This is not just something they want to do for fun. This is a need of theirs, and we're trying to meet those needs, and help them to be able to be more self-sufficient. So, and independent.
I want to interject too, real quick, Ron. I think also from a therapy standpoint and a team standpoint, there's 3 SLPs in our clinic. And if you feel like your child might benefit from another approach, I think 100% you can voice that, because every therapist is going to have a fresh pair of eyes, maybe a different way of addressing something. And so, again, parents, don't be afraid to just say, hey, can I get a second opinion on this? Or would you mind seeing if your colleague could take a look at my child, just see, or even, we just had this yesterday. We had a parent calling a whole meeting with the PTOT ST crew. I mean, it was a long one, but it was so well worth it because she got to express her needs for her child. So anyway, just know that it's not the end all be all if it doesn't work out with one therapist. I'm just going to say that.
And
And
don't
not
ever be afraid to ask questions.
Yeah.
We love questions. Because sometimes,
Oh, yeah.
as an OT, I like educating, that I think sometimes I do it a little too much and I don't want to overwhelm the parent, but with
Yes.
constant questions coming back at me, I'm like, okay, like they're ready to take on this next piece of advice or this next little bit of knowledge that I have for them. So never be afraid to ask questions. Like, hey, I see what we're doing right now. What goal is this working on? And just make sure that y'all are all on the same page always.
I think we'll take this last one from Laura, and then we'll probably, if that's all, and if we do have another one after Laura's last one, you can always I'm gonna, I think, post y'all's, if y'all are okay with y'all's email addresses.
Mhm.
I'm gonna
Yes.
email y'all some additional questions, and I'll make sure they know that, and they can reach out to me, and I'll make sure y'all get those questions. But Laura wants to ask about apraxia because it was mentioned earlier, and she's wondering if that's what our SYNGAP kids are experiencing. So if you, Morgan, want to briefly tell him what apraxia is, I do think Miller has a little bit of apraxia for sure. We see that in some of the phrases that he says. It definitely comes out from time to time. So if you want to tell him briefly what that is, and she can maybe decide if that's what she thinks her son or daughter has.
Sure. So childhood apraxia of speech is essentially it's a motor speech disorder. There is a breakdown that occurs from our brain to our mouth. Our brain wants to say something, but when our mouth tries to say it, it just does not come together as beautifully as we would hope it could. So that may look like saying sounds incorrectly consistently. I would say the hallmark of apraxia is consistently inconsistent errors. So your child may be saying words absolutely crystal clear one moment, and then the next it's like, well, what happened? What just happened? I have a little boy right now. I mean, he can tell me all about his farm and his day, and then when it comes down to doing some more structured speech planning tasks, that's where a breakdown occurs. And it's hard to definitively say, Laura, that is what the Syngapians are experiencing. It's not uncommon because I know from really the only one I have to base off of is Miller Man. And there were some characteristics, and we did do a lot of drill, but then we discovered that alternative communication was the best route for him to get his needs met immediately versus him trying to so diligently work hard to get those words out. So it's hard to say yes or no whether it's apraxia without seeing the child in person.
Yeah.
Hope that
And there's
answers.
also a lot because apraxia it's not just a speech thing.
Right.
Motor, it's a motor thing. So it's like she said, it's a disconnect between the brain and the muscles. The brain sends the signal, or tries to send the signal, but the signal doesn't always get where it's going or doesn't get there complete. The way I always like to describe it is that if you think about like an electrical cord, if that electrical cord is frayed, and you've got part of that, cord that's, not getting that whole signal is not getting to that, device, whatever it is like that. And like you're trying to charge something or keep it turned on or something like that, and it's not getting it. It's that signal's not getting there. And it's the same thing with your brain and your muscles. You want to do it, and you'll see that a lot of these are, even in adults, where you got somebody, we had one of our therapists in here the other day was trying to skip and wasn't able to do it, and like was watching like everybody else do it, and like she just could not get it. And so it's similar to that, where you're
I
just
need to
like,
know
okay,
who
I
this
see what
is.
it is. And yeah, and so that's why I say, it's a disconnect between the brain. And I think that's one of those things where we see it a lot with like our children with cerebral palsy and stuff like that, where we know that there's a specific injury to the brain, But with the SYNGAP, it's kind of hard to pinpoint something like that. It's not, unless you're doing MRIs and all these kind of different studies and stuff like that is more neurological. So I think research into that is something that would kind of help understand more of how much of this is a true motor apraxia or stuff like that.
Perfect. Well, I know Lauren did step away for a second. She might be back, but she's the one who would have to in the webinar.
I
She's
can hear.
here.
I can help you. I'm listening.
You're good. You're good.
Okay, thank
What do
y'all
you need?
so much. I was just gonna say if you were back, I think that's all the questions that we have live. So we're gonna end the webinar, but thank you all so
Thank you,
very
guys.
much.
That was really good. Thank you, Julie,
Thank
for
you so much for
organizing
inviting
it.
us today.
Yeah.
And I told him that again, if you have any more questions, we'll get those emails out, or you can reach me anytime with additional questions. And
I think I can speak for everybody else on here that if there is something that comes up where we get a lot of questions about a specific thing, and it would be easier to get back on and do something like this again, to where we could have a little bit more open communication and back and forth. Sometimes I know that's easier than just sending an email, to where because sometimes you ask a question, then the answer triggers another one and stuff like that. It's a little bit easier to do that. So if there is anything that or if there's other topics that come up that people have questions about, that may be something we could do in the future.
yeah, I know. I would love a webinar series. That would be great.
Yes.
So cool.
That would be wonderful. So, okay, guys. Well, thank y'all so much.
Thank
Thank
you.
you.
Thank
so
y'all.
much.
This was
Thank
fun.
everybody who got on. I enjoyed it, and I'm glad that we got to meet some new people, and
Yeah.
hopefully we were able to help a couple of y'all as well.
Absolutely. Absolutely.
Okay.
All right.
Bye.